can't tell you how long I spent staring at my slides, staring at my Word documents, trying to figure out what to say to you on this last day. And honestly, that's probably the toughest act I've ever had to follow. And what resonated with me about Bob and Linda, well, what didn't resonate with me is they put, they said they were a better ballet dancer. And as a retired ballerina, I think maybe next year we'll have a dance-off or something. But the other piece was that struck me about his work was really that he spoke to vulnerability, and that healing can come from the most mysterious and maybe even fun of places. So for me, I want to talk to you a little bit from the heart, because when I don't know what to say, it implies that I'm trying to say something that I don't feel strongly about. So I came up with this. So when I was an intern, AKA lowest man on the totem pole, I didn't know anything about neurology, and yet I'd gone into neurology because I was passionate about human behavior, why we do what we do. And as an intern, I was impressed with how much knowledge and language I needed to learn just to enter the field of medicine. And one night, or 1 week, I got to spend getting to know a young woman. And let's call her Brenda. Brenda was amazing. She was young, which I find amazing these days. She was young and vibrant and charismatic. And she was a jet ski instructor. And she had a family that adored her and a handsome boyfriend that doted on her. And she had a zest for life that I wish I had at that time. And I got to care for her as much as an intern can actually have full ownership over a patient for about a week or so. And we became kind of connected. And then something happened to her, of course, which was she developed ascending numbness in her legs, which is why she was admitted to the hospital, and she became paralyzed. And how could you not feel for her? And one night I was on call, one of the first nights I was ever on call, and the nurse called me and said, "Brenda needs you to come to the bedside. I need you to come over here. She has a question." And of course, as an obnoxious intern perhaps, I said, "Well, what's the question? Just tell me what it is so I can prepare myself when I go." And she said, "Well, I don't know. She won't tell me." I said, "Okay." So I get off the phone, and then of course, what are the thoughts that run through your head? Well, what didn't I tell her? I mean, I just rounded on her. Did I not answer something? Did I forget something? Is there something she wants to know that we didn't tell her about on rounds? Did I miss something? Notice all the default thinking questions, right? What did I do? How did I fail? And much to the nurse's dismay, probably, what I decided to do was to go learn everything I could about her problem, which happened to be transverse myelitis, or inflammation in the spinal cord, which was the beginnings of multiple sclerosis for her. So I ran back to my dingy call room, and I ripped out all the books, I opened my laptop, and I learned everything I could about MS. I mean, the symptoms, the prognosis, expectations, outcomes, treatment. I was good. I learned everything. And now, armed with my knowledge, I arrived on the floor about 20 minutes later. That's why the nurse was mad. But I was armed with all my new knowledge, and I was prepared to answer any question. And I walked into the room, took a deep breath, and I sat down, feeling confident. And my patient, Brenda, looked at me and said, "So I feel like we've gotten to know each other, and I have a question." And I said, "I'm ready." And she said, "I'm wondering if you think that I should marry my boyfriend so that someone will be able to take care of me when I'm in a wheelchair for the rest of my life." It was the one question I couldn't answer. It was the one question that maybe had no answer. And it was the one question that no amount of knowledge would have ever prepared me to answer. We talked at the summit about several themes, and for me, that conversation became woven into my fabric as a caregiver. And to echo Bob's point, it resonated with me in that moment that this work wasn't about me and my knowledge. It was about the people I served and the work. At this summit, you've heard about transparency. So I'm going to shift a little bit and expand on the concept, because I want you walking out of here, as I talked about, not talking unicorns and rainbows, thinking critically about what transparency means to the field right now. And in my world, transparency is important, as we talked about, because without transparency, you don't drive quality. And without quality, you don't deliver an exceptional patient experience. Quality, safety, patient experience, and value are tied together. That is what defines Patients First at the Cleveland Clinic. And it's an important thing to think about in your own world, that they can't be separate initiatives. They cannot, people must see the link between them. Transparency at the Cleveland Clinic has come to mean putting in front of providers, as with some of your organizations, their patient satisfaction scores on a routine basis. This was an effort that initially we did blinded, and then 6 months later we made it unblinded data, and now they see it every quarter. I'm sharing this with you. On the screen you see essentially what center the individual physician belongs to, what their inpatient scores are, what their outpatient scores are, and what their on-buds data is. So you're building a story across the continuum of their data, which is really important. One set of data may be flawed, but all three are probably not flawed. This is really important to get in front of your providers if you're hoping to change any sort of behavior. And then later, just last month, we did this public. So you can now Google me, although I hope you're not doing that. And you can look up what patients are saying about me online. Okay? So taking patient experience metrics and putting them out in the public. Why would you do this? Well, you would do it because the beautiful JAMA article last year that said of 10 to 12 websites that are rating physicians, patients are looking at them. And 60% of patients are choosing who they go see based on their online profile and what other patients are saying about them. You can't ignore it anymore. And the websites that are out there don't even confirm that that person ever saw you as a physician. So as you're walking out of here and thinking about transparency in your organization, I don't know where you are on that journey, but I want to share with you a couple things that I thought about, because when I stepped into the Chief Experience Officer role, we were in the process, kind of rolling this out and messaging. And I thought to myself, well, what a knock out of the park that'll be. I'll invigorate all my care providers because I'll be the one to tell them that we're going to put this online. What a success story that will be in my first 3 months, right? And so what I did was crafted a message that would address all the fears I was going to hear about. And this is what I came up with. So just looking at this before I move on, people can Google you. They see your star rating, which is now what CMS uses for those of you that are familiar with it. And then you can click on the comment buttons. There are now comments about me. You can click on them and it pulls them right up. If they don't have more than 30 surveys, they don't get online. Some of you attended the session yesterday from University of Utah. They're one of probably 5 or 6 organizations in the country that have done this, in addition to us. These are what I chose as my message. So when you think yesterday about some of the talks you heard about crafting a message that speaks to the fear that physicians and clinicians will have, this is really important. And speaking to the fear is important because, I got emails from companies saying, we're a reputation management company, and if you give us $200 a month, we'll tell you how to manage your online reputation. We'll monitor it for you, and we'll give you tips about how you could improve it. And as someone who cares deeply for her patients, I found it offensive, right? That this is the world, and yet part of it is the world. So I crafted a message that looked like this. Number 1, this work is about highlighting the exceptional work that you as a provider do. This isn't about shaming. It's not about any of that. This is about knowing that your heart's in the right place. And let's put that front and center. And people said to me, well, we can't publish this if, most of the, only unhappy patients write in, right? You know that, right? No, it's not true. And 93% of the comments as we went back and reviewed were positive. And so for the clinician who said to me, well, we can only publish these if greater than 92% are positive, I sent him an email afterward. I said, I have great news. 92.5% of the comments, I'm not joking, are positive. So highlighting, this is a forum to highlight you. 2, we are about transparency. Cleveland Clinic's about transparency. I'm sure your organizations are about transparency. Transparency is not putting all the positive out there without the negative. And we went so far as interviewing hundreds of patients to ask them, what do you think? Should we just have positive? Should we just have negative? Should we have both? And of course, patients are discerning patients. They're humans. So they wanted both. And in fact, they were quite forgiving if they saw negative comments about people who had a lot of positive comments as well. And so we value transparency, hands down. People asked about an appeals process, and we said no. You have an opportunity in our organization to respond to the comment, if you would like, in a personal way that I'll take a look at before we publish it. Control the process. This is a big one. And for those, I don't want to rehash all the information you may have heard, but part of the fear from your clinicians or caregivers will come from a place of losing control of their practice and seeing that this is just one more thing they don't have control of. And in a way, it's true, because many of those websites get millions of visitors despite no validation of what's published whatsoever. Okay? So we can control that. And oftentimes, the number of surveys that a given provider has is 2 or 3. So think about that. Millions of visitors are looking at 2 or 3 reviews to make a decision about you. It's not acceptable. We will control and own the process of our data. Must be greater than 30 surveys. Patient must have seen you, which is a huge leap in what currently exists. And this message worked. I haven't heard, it's probably been out of 1,500 providers that this impacted, probably 5 have emailed me, and 2 of those have been about, could you post some of my earlier positive comments? But this was about a carefully crafted message and strategy to driving your patient experience effort. Innovation. We talked about innovation the first day, and over the course of 3 days, 2.5 days, you've probably heard a lot of ideas, and all of us subscribe to the same concept. We're singing, I think, from a similar hymnal, as somebody told me, and yet we have to choose one direction. And innovation, in a sense, may actually be saying no, as Tom Lee said, to what we're not going to do, and being crystal clear about what we are going to do. Innovation can look like this, right? Lots of programs going on in my world, and I'm sure in yours, about how we can drive access, for example. Access is critical to innovation and patient experience. Patients can't access you, they'll never have an experience with you, and they'll go somewhere else, right? When we instituted our same-day access at the Cleveland Clinic a couple years ago, the volumes went up, and you hear patients say, well, I tried to get into such and such place because I went blind in my left eye, but they said they'd see me in 2 months. Do you think you, as a patient, would wait 2 months if you went blind in your left eye to be seen? Of course you wouldn't. So access, and many of these issues, so I won't go into detail about each one of them, but essentially the idea is that virtual visits are happening now. The insurers have to catch up with how we're expanding virtual visits, with the idea that anybody can be seen anytime, anywhere. Remote patient monitoring, so there's an eICU program at the Cleveland Clinic where our ICU staff monitor ICUs from across the organization that aren't staffed with full-time doctors and clinicians in ICU. So essentially all of their data feeds into a central bunker, so to speak, where there's a virtual monitor. If there's a concern of the nurse on the floor, she presses a button and we pop up on the TV screen. We can pull up labs, images, anything you need to know and communicate that to the nurse on the floor. So innovative healthcare delivery expands your reach tremendously. Clinical apps, you've heard about some of those who are doing wonderful things with extending the relationship, not supplanting, extending the relationship that already exists between a patient and their caregiver. Remote image upload. You talk about caregiver satisfaction. How many of you get mild to moderately annoyed having to upload images during your visit time? We shouldn't be doing that work. Patients can do it from home. So we have a website where patients can go in through MyChart, go in through the internet, and upload their outside images. So that when, by the time I see you in clinic, I have all the information I need. And I don't spend my time copying your 6 CDs into the electronic medical record. Online second opinions is another innovation. And I told you on the first day, innovation is great. These are all wonderful. And I'm beginning to think the most inspiring innovation is going back to the basics. You've heard this entire time, communication, communication, communication. So what are the innovative programs around communication? That's how I'm thinking about it. Engagement. So, let's see if I have it here. I used to put up this slide when I was talking about how physicians reacted to communication skills training. But I want you to think of, as I was staring at it last night, I thought about something different. How many people at your organization look at you like this when you start talking about patient experience? I mean, that's what I'm hearing. People are coming up to me saying, well, this is all great, but my CEO, or my nurse man, I need to bring you out, help us move them. So in my mind, much of this engagement, we're talking about caregiver engagement over here, we're talking about patient engagement over here. They're not disparate, disconnected efforts. These are my children, by the way. But if you look at the central image here, this is the one that always gets me, because we are healthy skeptics. This is healthy skepticism embodied in a 6-month-old. But we are healthy skeptics. Anything that comes across our docket, we're looking at it like, nah, I don't know. I'm not quite sure. Communication skills, patient experience, I don't know. And if we don't knock this out of the park the first time we do it, with the first initiative we choose, with the first program we design, what happens? What happens? What happens? I see you shaking. He's like, I don't know. Well, what happens is people develop immunity, I call it. They develop antibodies, right? Jim talks about this sometimes. It's a beautiful concept. And if you don't knock it out of the park the first time, people are immune to your efforts down the road. It's much harder. And that's important as you think about programmatic design. Must be well done. Our caregivers now are suffering in their own ways. Some days I feel like I'm dying a slow death from checkboxes and forms and emails and Epic and my beeper. I feel assaulted by the amount of pieces of information that are required of me. And if you think about it, healthcare has gotten so much harder to deliver, right? Clinicians say one of their major causes of burnout is because they can't spend enough time with patients. We're taking away their purpose in the work, and we're assaulting them instead with tasks. It is a slow death. Slow death of the spirit, maybe. And so, how can we design programs focused on the patient in the absence of honoring the suffering of our caregivers? It can't be done, in my humble opinion. And so I want to talk to you about some programs we designed and just how we thought strategically, understanding the audience that would have to sit through them. Before I leave engagement, I want to comment on a couple things which I said the first day. To me, it feels like an oxymoron for us to be defining patient engagement. It just doesn't feel right. I'm sorry. It doesn't feel right to me. Patients as our partners, as one of you sent me a note about, is the way to define engagement. And it's not just patient engagement, it's caregiver engagement. It just doesn't feel right. We must engage patients in defining patient engagement. We must engage caregivers in defining caregiver engagement. Or even better, let's just stop calling it both of those and call it relationship engagement or relationship activation. Or you heard Richard use the word co-production. Let's change the language. Not everyone wants to be engaged. I mentioned that the first day. And I still feel strongly about that, despite all the buzz about patient engagement, that we need to be very careful about the labels we use, because if you don't want to participate in my app and my patient education program or take your medication, are we going to then start calling those patients disengaged, right? Just like we call them non-adherent or non-compliant. There's some judgment attached to those terms. And it's a right to be disengaged in your healthcare, right? Like I gave the example, the mom with 3 kids who has a full-time job, she doesn't need or want a daily reminder about her MS. All she needs to do is to show up for her appointment every 1 to 2 years. And that's her definition of engagement. And that's enough. And lastly, as you heard me say, engaged patients with Walking Dead providers is nothing. We have nothing. So how can we do relationship engagement? And even when I spoke to Judith Hibbard, who does all of the patient activation work, I said to her, I think it's relationship activation. I don't get the patient activation. It feels like you press a button and your patients are activated. Congratulations, I, all knowing with all of my knowledge, have activated you. How's it feel? Not good, she said. Right? So, and I said that to her. She said, I think you're right. And she said, we also have a provider activation measure. So think about that. We have a separate provider activation measure and a patient activation measure. Shouldn't there be something in between? Something to think about. So it brings me to this concept of relationships, which you've heard me talk about many a time. I guarantee you in our organization, and if you read the books, they talk about how when Patients First rolled out in our organization, some of the language that ultimately evolved was patients first, caregivers second. There's a feeling when you say that. Has anybody had their providers react that way? You say patients first, and they're like, can you raise your hand so I can see if you're with me? Yes. Okay. So the idea is that it is patients first, but we can do that in a relationship-centered way, where you're honoring, again, the definition of relationship-centered care. Both people bring value. We have reciprocal influence on each other. This is a moral and emotional business that we're in. And so when we at the Cleveland Clinic, when I was charged about 6 years ago to develop a communication skills program for all of the staff physicians, at first I thought, oh great. Second, I thought, wow, I mean, how are you going to engage experienced clinicians in communication skills training? And we got a group together and started doing it, and we trained about 1,000 providers and 1,000 staff physicians in, not residents, not fellows, not med students. After training 1,000 providers, we realized that providers don't view part of their job as establishing relationships with their patients. Instead, we've bred, I think some people, we've created a system that makes them taskmasters. And so their scope has narrowed to, my job is to put this patient asleep. My job is to fix the knee. My job is to get her vision back. And it's not to heal in the broader sense. And it fails, I think, to recognize that we have an opportunity, if we choose it, to form relationships with our patients that can be therapeutic and healing when all of our knowledge fails, and it will. So there are many models of communication that exist, but we designed our own based on this concept. Because teaching experienced clinicians communication skills has to be meaningful for them. It's a core principle of adult learning. And we wanted not just to give them skills, a list of skills, smile and thank people. We wanted to tie it into their fabric, just like my story became woven into mine. We wanted to nudge their thinking about relationships and what their role was in forming them. And so we developed this approach. The communication skills are listed. But to give you an example of it, I thought I'd do this. I've listed here on the one side things that people have told me that people say to them when they try to bring patient experience efforts in. And so I thought I'd give us a dose of reality just for a minute. So they say things like, this is all fluff, right? You want me to hug my patients? You want me to run off into the fields and hold hands? Really? And the first thought that runs through your mind is, no, it's not fluffy, and I'm not enjoying this conversation, and I think you're kind of Dorothy. Right? I'm asking you to consider saying that, but not to say it. What I ask you to say would be, tell me more about why you think these are fluff. Have you had some prior experiences with this type of work and it didn't feel right to you? Or you sound frustrated. I've heard that a lot. And then what you should go do, if you're trying to engage that person, is to go get a partner of influence, I heard it called. I call them nodes. So know who your nodes are within your organization. And when I say node, I mean you're somebody who's tied into the network of your organization that has organizational power, influence, reputation. And for me, as we were selecting facilitators of the communication skills program, that was often experienced surgeons. Because for me to teach you communication skills is totally different than to have the chair of neurosurgery teach you communication skills, who happens to be a male in his 60s, 70s, right? It's just different. So you need to find your node, your influencer, and you need to engage the node. Doesn't matter if they're on board with your work or not. You need to bring them on board. So think about where your organization is on readiness to change. Are they anti-change? Like smoking, right? Anti-contemplative about change with respect to patient experience. Pre-contemplative, they're thinking about it, but not quite. Ready and on the way, right? Ready to take action. I think about it like that. And if you can gauge where your organization is and where your nodes are, you can adjust your strategy. I gave you a couple other examples just in case you've ever heard these. My patients already like me. And you think, no, they don't. Don't say that, right? Try the next one. Great. What skills do you actually employ that you think creates that perception? And you know what they'll say then? I don't know. And I don't know if you've ever talked to your providers, but being nice isn't an intentional skill. In order to reinforce what people are doing that builds a better patient experience, you have to be able to identify the skills that make people effective at doing that. And most providers who are good at it can't identify those skills. So helping draw them out to identify the skills. So what I would say is, great, what skills do you have? And then I would pull actual comments, and I would spend time following that provider so that I can see what skills they're using, reflect that back to them, so the next time they go to teach their team, their colleagues, or are talking at a staff meeting about why their experience scores are so high, they can identify the skills they use. Really important. Being nice, in my mind, is not a skill set that drives effective patient experience. This is about the team, it's not about me. Consider, no, it's really you. And then don't say that. Say, you're probably right. I wonder if it's worth thinking about how we could more effectively engage the team. What are your thoughts on that? Only unhappy patients write in, no, they don't, is what you're thinking. And what you're going to say is, yeah, many people think that. It's interesting, though, in the data, it doesn't pan out. Lastly, this is just about the money. This is just about this HCAP stuff. And your answer is, oh, could I have some money? That would be great. But I want you to say something, or I think about saying something. I'm not telling you what to say. I'm just telling you what I would say. I would say, well, you know, for some that might be true, but I think we have a choice. Could be, I could choose to make it about HCAPs, but I don't. It's bigger than that for me. I'd encourage you to make the same choice. So the difference between the language under the say column and maybe the language under consider saying, in my mind, is relationship-centered approach. Do you notice something in common about that language? It's the same language we're asking them to model to our patients. We, as empathy amplifiers, must model that language to our colleagues. At this organization, I think we've been successful because this was our approach. Never in our facilitation, as we train 60 clinician facilitators to do this work, and this work was done in person. I appreciate technology and online training, and I think that's all great. But if we're saying we value relationships, we also need to value that relationships with our colleagues are formed in person. And at least initial work, I would advocate, should be in person. Because the hidden agenda of this work is to build relationships amongst the colleagues with the organization as well, in the training itself. And when we did that, we ultimately trained about 5,000 experienced clinicians, staff physicians, and ultimately residents, fellows, and advanced care providers. But we started with staff because they are the leaders of the team. And if everybody else looks at them and learned a certain language and the staff don't model it, what happens with efforts like that? They go nowhere. So this was about giving a framework for language. And I'll tell you something about framework. If you roll out programs that just give providers a skill here or there, we need you to smile, here's your acronym, smile, listen, something, something. And they don't see a broader framework for it, your acronym will have a short life. I think the idea is to create a broader framework of language and then reinforce it all the time. So you reinforce it when you go back to do end-of-life training. You reinforce it when you go back to do safety training. You reinforce it when you go to do quality training. You reinforce it when you go to do professional development training. Because they must see, learners, I love the brain, of course, but learners, adult learners, which is really what many of you are working in, whether you realize it or not, learn new knowledge in the context of things they already know, right? So it's better if you have a common language you can reinforce all along the way. They learn it better if it's grounded in their real world experience. So in our training, we offered the opportunity for them to share their cases, and then we worked through their cases with the same language every time. And they're self-directed. They'll come up with their own goals. I'll have my goals for them, but what's most important is their own goals. So truly being learner-centered, adult-centered, person-centered in the programs you roll out, in my mind, is the key to success in this day and age. The other thing I would say is about messaging. When we message something like communication skills training, and the communication skills training ultimately had significant impact on Jefferson Scale of Empathy, Maslow Burnout Inventory. Why? Because if you read the literature on burnout and resiliency, they talk about how communities and relationships are one of the primary strategies that clinicians who don't get burned out use and develop. So how can you evolve a community of people to improve their resiliency? In our scenario, we leveraged communication skills training as a means of engaging them in patient experience. Do you see the link? Does that make sense? That we didn't say, we want you to engage patient experience, you got to get your HCAHPS scores up. We said, tell me what your toughest cases are, and I'll help design a program that will help you navigate in this exceptionally difficult environment. It's a different message. And you just heard about neuromarketing, right? You just heard about it. So I don't care what it is, whether it's neuromarketing because you're fascinated with the brain, or you're like Plato, who thinks that the brain is driven by an emotional horse and have you heard this before? Plato came up with the idea that there are two horses that lead the chariot of the brain, so to speak. And one is an emotional horse, and the other is a more left-brained horse, a more data, logic, reason. And you hear this pop up in books now, right? There's books written about this. Who moved my cheese? Things like, you have to appeal to both. And so crafting a message, crafting a program that appeals to both helped us, and I hope it helps you. The last point I want to make about relationship-centered care is that it's nice because it's portable, right? It's not this weird thing we do with patients and then we go to talk to colleagues and we abandon the language. That happens all the time, right? Well, I learned patient-centered communication, but you're just a jerk. It doesn't make any sense. The same skills are portable to any conversation. And that's important because we heard about Darth. Darth has come up like 18 times now. But Darth wasn't always Darth. Who was Darth? You don't know who Darth was? Darth was Anakin. And who was Anakin? He was a guy that loved his wife, and then he lost her. The suffering of our patients is yet not unique to patients. We have it too, and it could make you do odd things. So my question when I meet Darth is, where's Anakin? And that's what gets me excited. I'm going to find Anakin.